Good afternoon, everyone. Welcome and thank you for joining us today. Today's webinar, Patient-Centered Dysphagia Management, Integrating Lived Experience and Clinical Strategies for Better Outcomes, will be presented by Dr. Ashwini Namasavayam McDonald and David Jameson. I'm Erin Bailey, Medical Affairs Manager with Nestle Health Science, and I'll be your moderator for today's session. This webinar will provide evidence-based insights and practical approaches to support successful dysphagia management at home. Dr. Ashwini Namasavayam McDonald will share key research findings on the psychosocial and caregiver burden of dysphagia. She will be joined by David Jameson, a head and neck cancer survivor living with dysphagia, who will share his personal journey and lived experience. Together, they will explore what it truly means to support individuals living with dysphagia and discuss strategies that can improve patient outcomes through person-centered care. I just have a few housekeeping notes. At the end of the webinar, there will be time for questions. So if you could please enter your questions into the Q&A box to the right of your screen. Also, once the recording is ready, you'll receive an email with a link to the webinar recording, as well as your certificate of attendance. I'd like to now introduce our speakers for today. Dr. Ashwini Namasavayam McDonald is a speech-language pathologist and associate professor at McMaster University, where she directs the Aging Swallow Research Lab. An internationally recognized leader in dysphagia research, her work focuses on improving quality of life and care for individuals living with swallowing impairments, particularly older adults and those with dementia. Through her multidisciplinary and co-design approach, she bridges research, clinical practice, and lived experience to promote equitable, person-centered dysphagia care. David Jameson has been living with dysphagia since 2021, following treatment for head and neck cancer that included surgery and radiation to remove a tumor, several lymph nodes, and the base of his tongue. A 63-year-old retired broadcaster and father of 3, David now navigates the daily challenges, fears, and social isolation that can accompany dysphagia. He is a passionate advocate for advancing dysphagia research and improving clinical support for those affected. We are very excited to have Ashwini and David leading this discussion today, and now I'll turn it over to Ashwini.
Thank you so much for that introduction, Erin. Here are financial disclosures. And I was hoping to start with a land acknowledgement today. So as someone whose parents immigrated to Canada and who was raised here as a settler, I want to begin by acknowledging the lands that have shaped both my life and my work. McMaster University is located on the traditional territory of the Haudenosaunee and Anishinaabe peoples, protected by the Dish with One Spoon Wampum Agreement. That's a treaty that calls for collective care and peaceful coexistence. I also acknowledge the treaty's 6th territory where Edmonton now stands, and that's where David is. Those are the traditional lands of many First Nations and Métis communities. Our presentation today focuses on dysphagia, quality of life, and caregiver burden, as Erin mentioned. These are all deeply personal and often invisible experiences, and these too are shaped by the legacies of colonialism and the ongoing inequities in access to care, support, and voice. So particularly for those Indigenous peoples and other marginalized communities. Acknowledging the land is one small but necessary step in recognizing these broader contexts and in committing to more equitable person-centered care. Okay, and with that, I'd like to just start by talking about what is health-related quality of life. And one definition is an assessment of how the individual's well-being may be affected over time by a disease, disability, or disorder. But we're here to talk about dysphagia. And when we think about dysphagia-related health-related quality of life, we're talking about the quality of life directly impacted by the loss of pleasure from eating, fear of choking, and loss of independence, and many more things that are associated with dysphagia. So I really like this Wilson-Cleary model of health-related quality of life. This model links clinical and patient-reported outcomes in a hierarchy of 5 domains. So there's, as you see on the left, there's a biological and physiological variables, so like disease status, lab values, physical impairment. We have symptom status, so pain, fatigue, swallowing difficulty. We have functional status, so that's like the ability to eat, communicate, perform daily tasks. We have general health perceptions, how patients rate or interpret their own health. And then overall quality of life, so someone's emotional well-being, satisfaction, and social connection. And then plus, we have individual and environmental characteristics like age or support systems that influence all levels. So if we were to apply this to dysphagia, when we think about symptom status, we would think about, for example, difficulty swallowing or fear of choking. And if we were thinking about functional status, we might think about eating in public or speaking clearly. And if we were to think about quality of life, we might think about social isolation, reduced employment, or identify the impact of the dysphagia. So our lab took this model and did a review of the literature to see what are clinicians asking about in terms of each of these domains. And what we found is that we are asking about etiologies, symptoms, and the functionality associated with dysphagia. However, few are considering general health perceptions, overall quality of life, or the modifiers of environmental or individual characteristics. And we know those personal and environmental characteristics can significantly modify biological functions. So, for example, through predisposition to degenerative conditions. Conversely, individual characteristics such as enjoying exercise or high levels of health literacy can be protective against disease decline. When we think about personal characteristics, that can be like gender. When we think about environmental characteristics, it can be a supportive community or the ability to travel to appointments. So I'm saying this so we can all start to think about how we can, as we build rapport with our patients, start to think about how we can ask about these things and get a sense of the whole person and not just focus on those etiology, symptoms, and functionality. And anyone who knows me knows that I love this book and I love putting a plug in for it. If you have not read it, it is a must read if you care about this topic. I read it as a new clinician, a new grad, and it really changed the way I practice. So essentially, it's written by a physician, and it's written for families, but I took away a lot from it on a personal and professional level. Essentially, this physician basically begs us to ask the question to those we love and those that we're caring for, whether professionally or personally, what makes life worth living to you? And understanding that helps us shape the decisions we make or help make. And one dysphagia adjacent example that I remember quite clearly from the book is there was a man who was undergoing eye surgery, or he had some eye issues, and they proposed this eye surgery, and there were not very good odds that it would work or be successful. And they said, what makes life worth living to you? And he responded, if after this eye surgery, I cannot sit on the couch on Sundays and eat my ice cream, this is not worth doing. And, I think sometimes we take for granted how simple people's wishes are and what is important to them. And what this book shows us so eloquently is that so often as professional and personal caregivers, we make decisions that make us feel good without thinking about what the patient really wants. So again, I'll plug, if you haven't read it, to read this book. So let's jump into dysphagia-related quality of life. We know that there is a constant trade-off between physical safety, so like aspiration, pneumonia, choking, and enjoyment of food for people who have dysphagia. Many report feeling like they have paid a really high price for safety. So they're isolated, they are restricting a lot of what they're doing just to be safe. These individuals, patients like David, report poor mealtime experiences, including including effortful swallowing, fatigue, unpleasant textures, persistent thirst, especially if they are NPO or nil by mouth, so not allowed to have anything by mouth and are being tube fed. We know that adults with chronic dysphagia describe reduced choice and control over food, feeling that others decide what is safe, which diminishes their autonomy and dignity. And I think that comes down, and we'll talk about it on the next slide, to this lack of shared decision making. When we think about health-related quality of life overall and dysphagia's impact on that, several studies have now shown dysphagia's negative impact on overall quality of life. And in 2 studies from my group, we have shown that dysphagia is an independent predictor of health-related quality of life in both stroke survivors and veterans. So essentially what that means is that we did these studies where we asked people about their health-related quality of life, so nothing to do with dysphagia necessarily, but just overall, how they would rate that. And then we took a whole bunch of other factors that we had from their medical records and other places, and put this into a statistical model to see, okay, what is actually making a difference in their health-related quality of life, for better or for worse. And dysphagia was something that affected quality of life, regardless of things like disease stage, lesion location, type of disease, support systems, et cetera, et cetera. So really, really important thing to pay attention to. But what do we do about this, right? I think we have to actively involve patients in meal and texture design. We have to discuss flexible and adaptable options. And we need, like, for the sake of quality of life, we need to retain some favorite foods, maybe in modified form, but we need to talk about what that looks like and negotiate risk in an informed way. You know, it's not just about, this is unsafe, you're going to get pneumonia, but like, what is contributing to pneumonia? What contributes to pneumonia? What other risk factors can we lower here? I think we need to have an open discussions about lifestyle impacts and shared decision making, as I alluded to earlier, to improve acceptance and meal satisfaction. So we don't prescribe diets, we recommend them, and we have really informed discussions about the pros and cons, because there are cons to everything, even the things that we have the best intentions of for when we recommend. And then, of course, incorporate treatment strategies that maximize social functioning and minimize burden on the patient. Now, when we think about dysphagia-related caregiver burden, family members of individuals with dysphagia report experiencing increased feelings of anxiety, burden, distress, fear, frustration, sadness, and isolation. They report a loss of social bonds, decreased life satisfaction and quality of life, and they have repeatedly reported negotiating a new normal, trying to figure out, what does this new normal look like? And unfortunately, as clinicians, we may be unintentionally contributing to such burden. So often we are focused on the impairment itself and the supports that the patient themselves needs to be successful. And we're asking caregivers to be supporters, advocates, trainers, chefs, recorders, companions, maybe more. And we're placing a really high demands on those caregivers providing support. But we have to think, what are the consequences of such demands? And a lot of the research we've done in my lab, and along with Dr. Samantha Schoon at the University of Oregon, has shown that this is cyclical. It's a vicious cycle, because we think we have the best intentions and we're asking these caregivers to do so much, but there is a direct link between caregiver health and care recipient health. And when the caregiver is overwhelmed and feeling burdened and stressed, the care recipient, that patient, doesn't do as well. So we need to think about the whole family unit. So then this begs the question, how can you change your clinical practice to better support caregivers? And there's several ways we can do this. We can ask brief, structured questions about meal-related workload, emotional strain, and confidence with recommendations. We can engage caregivers in conversation and validate their feelings. It's okay to say, this is a lot of work. We can share red flags and who to call for help. So what I mean by that is, like, here are the warning signs. This is what you need to look out for. You don't need to know everything, But if you see like a fever and paired with this and this is who you call and this is what you do. You go straight to the emergency room, right? Or whatever it is. We provide education to both the caregiver and care recipient, both verbally and on paper. We've seen time and time again across healthcare that people are not taking in everything we say. We need to write it down for them ahead of time and hand them that paper. Don't rely on them to take notes. We can't bombard the caregiver or the care recipient with information. And I think there's a need for joint SLP dietitian sessions that are prioritizing simplifying diets and strategies, minimizing separate meal preparation, using ready-to-use or easy-to-prepare options, and clarifying which rules are non-negotiable versus flexible. Like maybe it's non-negotiable that you do oral care before every meal and after every meal to reduce pneumonia. But what's flexible is, you know what, if you want that glass of wine, a piece of birthday cake once in a while, I think that's okay. Ask if caregivers feel capable of carrying out the necessary caregiver duties. Avoid using medical jargon when talking to patients and caregivers. Make referrals to counseling when appropriate or necessary. And lastly, suggest joining a support group. We have in our lab, we run a Canadian-wide virtual dysphagia support group, which I'll give you the information for at the end. But it is absolutely remarkable, the support. Our caregivers and adults with dysphagia report, and they feel much less isolated. They spitball ideas and suggestions, and you see that need for a community. So help them find that community. So as clinicians, when we think about the management of dysphagia, we have to consider various factors highlighted in this figure, right? So the speech language pathologist, the dietitian is responsible for carefully balancing these factors when making decisions regarding dysphagia treatment. So goals, quality of life, empowerment, underlying disease process, potential for improvement, care environment, care burden, and cultural values. And so often it's just too much, right? Like how do we consider all these things? How do we get all of this information? There are frameworks like this bolus framework that helps us get at some of these things. So this bolus framework created by Aaron Padilla and Phyllis Palmer from the University of New Mexico suggests that like we need to think about bolus variables like the pH of the bolus. So are they drinking water versus orange juice? The viscosity, the frequency and amount, level of aspiration and response to aspiration, oral care, lifestyle and activities of daily living. So is our patient dependent for oral care and feeding, mobility and activity levels? Do they smoke? Do they drink alcohol? Then it asks us to look at unintended iatrogenic risks, and then overall system health. And if you look up this paper, or you're free to email me too, and I'm happy to send it to you, it has the checklist and questions that you can ask, and you can kind of go through and help in that shared decision making and show where the vulnerabilities lie with your patient, and really think about this a little bit more holistically. Now, the problem is research by Dr. Brittany Kreckler at the University of Cincinnati has shown that adherence to dysphagia recommendations is only like 22 to 52%. And what her review showed us is that there are both barriers and facilitators. Some barriers are denial of the problem, the task was difficult, remembering to perform exercises, pain, fatigue, too busy. They're questioning relevance or low motivation. They're living at home, dissatisfaction with texture or taste, indigestion, social implications like isolation or depression. And then we have facilitators that I think we really, really need to keep in mind. So things like written instructions, as I mentioned before, eating alone to avoid distractions, increased physical conditions, psychological well-being, high motivation, and social support. So I think it's really important for us as clinicians to think about, like, you don't need to implement all of these facilitators, but what can you pick one or two of these things and help to maybe increase motivation by explaining what's going on, or providing those written instructions, or referring to support group for social support. So thinking where we can facilitate to improve adherence, because otherwise we're left with the question, was the therapy we recommended ineffective, or was adherence poor? Was it poor because they didn't want to stick to the recommendations? They were overwhelmed, overburdened. We asked too much of them. So we really need to keep in mind dysphagia-related illness is rarely just about swallowing. It is a symptom of broader vulnerabilities, and treatment starts with early identification, multidisciplinary collaboration, and family-centered strategies. And notice I didn't say person-centered, family-centered. When we intervene, we aren't just preventing pneumonia or weight loss. We are helping to preserve function, quality of life, and dignity. And with that, I would love for you to now meet my friend and colleague, David. And together we are going to talk about his diagnosis of dysphagia and onset, daily impact and identity, communication and advocacy, caregiving support, and then we're going to reflect on this in the next 30-ish minutes. So welcome, David.
Hello, Ashwini, and hello to everyone, and thank you for joining us today and allowing me some time to share my story. As you heard at the outset, I was diagnosed June of 2021 with head and neck cancer, which obviously is life-changing in and of itself. I underwent surgery July 30th at the University of Alberta Hospital in Edmonton. I spent 12 days there. When I emerged from the fog of surgery, not only did I have a lengthy scar across my throat and neck, I could not swallow. And naively, I thought that once I healed, the tumor was out, the lymph nodes were out. I didn't know what a base of tongue was, but it was out, and that I would return to normal, whatever that was. I did not. I emerged from that and then underwent 6 straight weeks of daily head and neck radiation at the Cross Cancer Institute. I lost a tremendous amount of weight and required a feeding tube inserted through my nose. I lost almost 35 pounds and was in a very precarious physical and mental state, as you can appreciate. At this point, I still have not heard the word dysphagia. No one's talked to me about that, and I must frame all of this by saying I had exemplary medical care throughout. But I am only thinking of myself as a cancer patient who is now coming out of the things required to not be a cancer patient. Again, I am not anticipating a chronic and lifelong condition. It was about a year after I'd come through all of that now I've got a name. One of the people I was dealing with said in the course of a conversation, well, you have dysphagia. And I said, I didn't know how it was spelt, never heard it. And they walked me through what had been done, and it was the base of tongue. The tumor I don't miss. The lymph nodes I probably do miss. The base of tongue I really miss from my body, and the function it performed, because like a lot of people, you've been swallowing since you were a baby or shortly thereafter, and I never gave it a single thought as to how all of that worked. So now I had a name for my condition. I had to not only heal from the physical trauma, and I'd lost almost 80% of the strength in my left side of my upper body because of the surgery and all the nerve damage. My jaw is no longer working properly, and I have dysphagia. So it was a physical burden, and it was a mental burden that I still have not entirely, wrestled to the ground, if I ever will, as to what this has done for my life. It's been profound. What I've lost in terms of enjoyment, Ashwini has touched on this earlier, and I know we'll talk about it a little more as Ashwini and I go through this, but so I tell people, who ask, well, are you cured of your cancer? I said, well, I might be, but what I do is I had cancer, but I live with dysphagia. That is an everyday condition The 3 worst times of my day are breakfast, lunch, and dinner, because I have to make a decision. Can I eat safely? Is what I'm putting in my mouth going to, on some level, nourish me or give me pleasure? Because let's not forget, there has to be some pleasure in consuming whatever it may be. And yeah, can I do, and also, again, we've touched on the isolation. That's profound. I no longer go out for lunches, dinners, breakfasts. I eat alone. And if I do, on the rare occasion, if I do consume food with others, I do it only with those I've told about my condition. Most people I come across, they've never heard of dysphagia. So I need to know that I have a safe environment, that the people with me know that at any point I could choke. I had the worst choking experience of my life just last week. I was eating alone, and it got to a point where I thought, I don't know if I am going to come through this. I may have to call for help, but I couldn't speak. So it's a profound change to my life, and for all of those who are living with it, I'm sure they can relate on many levels to what I go through on a daily basis.
Yeah. I mean, so I will share that David had not shared about that choking incident with me previously, and I have seen him choke before. I have had the pleasure of eating with David and watching him experiment and try new foods. But maybe, David, you could talk to us a little bit about initially and now about your expectations about recovery and how you've negotiated that.
Well, how I've negotiated recovery, and I don't even know if I know I won't get appreciably better, but what I am getting better at, Ashwini, is managing my condition. So with food choice, and as you have witnessed, I eat very slowly. I know we're told as kids, eat slowly and, savor your food. Well, I have to savor my food so I don't end up choking. And how I manage it now is, and I still have days when I get sad, when I have a choking incident, when I come out of that and I sort of settle myself and, reset and try and either continue my meal, or in some cases, I just walk away from it. I go through my day quite hungry a lot because I have to kind of negotiate with myself. Is eating whatever it may be in this moment worth the trade-off to the bad thing that might happen? Now, what I'd like to say is I don't live in fear. I respect my dysphagia. I'm not fearful of it. I mean, there are days when I might be a little scared of it, but I have to respect it. I have to respect the change in my body. I can't take a pill. I can't take a shot. All I can do is practice some of the things you showed in that slide, the oral care. I'm vigilant about that. I am, again, I try to put myself in a position when I'm consuming food that I am safe and comfortable, but I am not entirely at peace knowing that I will likely not get better. In fact, I might get worse as I age. I'm 64 now. And it's not easy.
Yeah. And I think David and I have talked about this a lot, this recovery process. And early on, did you, correct me if I'm wrong, you did think things could get better, right? Like very, very early on.
Very early, because, I'm of a mindset, well, if you just work hard enough at it, and I would like to also just sort of roll in here as part of my recovery is I undertook with the Alberta Cancer Exercise Program at the University of Alberta, I incorporated physical activity into my recovery, which as much for the physical benefits, and Lord knows I needed a lot of benefits, there was the mental part of that, the cancer, coming out of that diagnosis and the surgery, but also then sort of getting myself healthy enough to then, if you will, plow forward with dysphagia.
Yeah. Yeah.
So I was working on two key pillars, the body and the mind. And I've recently gone back to the Alberta Cancer Exercise Program because I felt it was just, it was essential to my well-being. Does it tangibly help me in trying to swallow part of a sandwich? I can't say it does, but I don't want to imagine what life would be without me having, at least on some level, addressed my physical and mental well-being.
100%. And I will just put a plug for our research that actually David was a patient partner on, or community partner on. In our lab, we did a study looking at how physical activity and physical exercise moderates the relationship between frailty and dysphagia. So what that means is, how does it strengthen or weaken that relationship? And what we found in that study, if you remember, David, is that physical activity, increased physical activity and increased physical exercise actually reduces the symptoms of dysphagia. People are going to experience less symptoms when their whole body is strong. So I actually would hypothesize that if you didn't do that physical exercise, you probably have worse swallowing outcomes. So,
well, that's good. That's more reassurance to continue doing the work. And I will tell, as part of that, I mean, selfishly, I'd given myself a goal coming out of my cancer surgery and the radiation was to go back to work, which I did. I was a broadcaster in Edmonton on radio, working for TSN and Bell Media. And I said, okay, I got to give myself some goals. And one was to get back to work, which I did. Within 10 months, and there was a period of about a month where I lost my voice, which would have been very problematic given my previous employment. But there was also a goal I'd set for myself to be able to return to playing tennis, which I did. I wasn't very good, but it was just the idea of saying, giving myself a North Star to point towards, and
so important, right? To have these
yes.
goals and thinking like, did you share those goals with other people? Did people ask you about these goals? I think the other thing that's important to keep in mind for everyone watching is that, we're not in the business. Well, maybe some of you are, but I'm not in the business necessarily of physical activity and physical training. But I will tell you that the research shows that even a 10-minute walk every day will reduce the incidence of depression. And do you know how many of our patients with dysphagia suffer from depression? So there are small things that we can share that might feel like low-hanging fruit to them and so much more doable than these unintuitive exercises that we might prescribe. With that, you alluded to how you often eat alone.
Yes.
Can you talk a little bit how that shaped your interactions with your family? Your children?
That's had a profound effect. I see my children less. They're adults and they have busy lives and I, like a lot of people, probably took for granted personal interaction, with your kids, or the rest of my family lived elsewhere, and so they're not here close by. And I have said no to opportunities to get together. So what I do is I for those who don't know, and when my kids obviously know my condition and what I go through, so I will defer a lunch or a dinner opportunity, which would be wonderful, and say, let's just meet for coffee. They get it. They understand. They know sort of the mental anguish I go through. And so it's, it speaks to what I referenced earlier is the isolation. You feel like you're missing out on life. And I don't want to paint an overly bleak picture. I have a busy life, and this is part of it. And I do socialize, but it's with guardrails. It's not fully engaged. It's, I think about traveling. I was asked recently, well, can you travel? And that concerns me. If I were to be away from home, I gotta, where am I going, and what can I, on some level, guarantee that I can feed myself?
Mm-hmm, mm-hmm. Yeah, even when we go out. So David has traveled with me to co-present at conferences, and I find myself like always looking at the menu and then double checking with David ahead of time. Like, will there be
Yeah.
something that he is comfortable
Sure.
eating and doesn't feel that pressure, right? Do you, to kind of just like pick on what you are saying a little bit about your kids, can you tell us a little bit more why you're deferring? Are you scared? Do you not want to put them in a position where they're scared? What is
Exactly.
it that makes you?
The latter, what you just touched on there. I don't want them to be in a position where if we were to go for a meal, I would have an episode that they would be forced to deal with it, perhaps do the Heimlich or see me in a public setting. I had an almost episode last year with my eldest daughter and her now fiance. And you're sitting there, you're thinking, I don't want to ruin their outing, and I don't want to spoil it for people, around me. And so that's why I defer. It's less about, I've been through it so often now where I've choked and had to deal with it that I can, I'm okay. Like I always say, like I'll figure it out on my own. I don't want to bring others, if I can avoid it, into my dysphagia.
Yeah, but I find that, like, I think that speaks so much to the isolation, David. Like, you would rather choke by yourself and not have, I'm sorry to say it out loud, but not have an option to call for help than to like put those that you love and care about in a position where they might have to see you do that.
Exactly. And and I'm certain that I am not unique in that.
No, I don't think you're unique at all.
No, because choking, and for those who haven't either experienced it or seen someone in the throes of it, it is when you're struggling for breath, as I was just last week. It's frightening.
Yeah. Yep. It would be. It's a lot.
Yeah. And again, that speaks to what we've been alluding to throughout all of this, which is it's a physical condition, but it's a mental one as well.
Yeah.
And both have to be addressed on some level.
Yeah. That said, so thinking about the mental load, do you have strategies that have worked for you, or resources to, other than exercising, to offload some of that mental piece?
I have learned, and I'm not perfect and probably will never get to that, to be less hard on myself. Okay. And I know that sounds rather sort of vague and, but what I mean by that is to not judge myself so harshly if I have an episode.
Yeah.
There are other things I do. I'm an avid listener of all sorts of different music, and I read a lot widely. Those help calm me. But in the moment, and, let's go back to what happened last week. Early in my experience with living with dysphagia, I would have been very down. I would have been mad at myself because, again, early days, I didn't understand what I was living with. I'm clinging to the idea that I'm going to get better because I'm thinking of it solely as cancer, the result of surgery, and it will get better. Not that I've now moved into a new category. So now what I've got my mind at some level wrapped around what I have, which is, I treat myself more gently, and I'm less, okay, settle yourself, go back to eating, calm yourself, step away if you have to. It does require, though, some significant mental discipline, because it's very easy to just sort of throw up your hands and say, I'll have whatever. And, it's a challenge to feed yourself, nourish yourself with good food. You and I laugh about early days, and all I could eat were onion rings from a popular fast food restaurant, and I would eat them in my car alone. And I would do that because they were one of the few things I could safely consume and go, okay, I know I haven't put anything good into my body, but mentally I made myself feel better. You know, I tricked myself into thinking I ate properly. I didn't, but, you know, at least in the moment I went, okay, now move on to whatever the next task was going to be. You know, and the other thing is that, and again, I probably won't be unique in this in terms of dysphagia patients, is I try to think myself out of being hungry. So there'll be points in the day where I go, I really should eat. And I'll just go, forget about it, keep moving. You know, when I was at my worst, I was down to 137 pounds on a feeding tube, and I was really struggling with lots of things. And I was at the cross, and I remember it distinctly. They were worried that I was getting very close to anorexia. I'm thinking, wow, this has gone from, you know, a cancer thing to, again, not even talking about dysphagia at this point. So it's really changed my relationship to food for a bunch of reasons.
Yeah, of course. Have you ever felt unseen in this journey, where people just don't understand you and don't get it?
Every day. I've yet to meet, I did have the pleasure of meeting a young man on a call like this recently, 17-year-old man who is incredible. I've never met someone with dysphagia. And I'm at the Alberta Cancer Exercise Program twice a week. And I've never sat down with a man or woman across from me and go, hey, you've got what I've got. I mean, people will see me with the neck scar, and if I see someone, you know, kind of, there's an acknowledgement. But I have a friend who has the same scar, but he didn't have base of tongue removed. So his condition is different. He had cancer and has now moved back to normal, as it were. So unseen, absolutely. I still have to spell dysphagia. They think I'm saying some word that they, you know, may have heard. They don't know it's a condition. If, again, on the rare occasion I'm out with them and there's food involved, they'll go, can you try this? Can you try this? And, you know, I feel like a little kid and adults are introducing new foods. You know, like, you know, so it's being unseen. Yes, that's a real thing. And, you know, once people do understand, they're very supportive, and they, you know, they do try to learn a bit more about it. But yeah, it feels like dysphagia is, you know, I feel like some days I should wear a shirt that says, ask me about dysphagia.
I'm going to pick on you a little bit. I have two last questions. One, I've never asked you before, but I'm thinking that other people on this call might have this same question, given what I said earlier about our support group. So you and I met through the support group.
Yes. So
he joined a meeting. That's how we connected, that I was moderating. And I reached out because obviously he speaks so eloquently, and I was drawn to his story. But David, you never returned to the support group. And I'm wondering if there has been a hesitancy, obviously no pressure, but like, you know, you talk about this feeling unseen and not getting to talk to someone. Is there a hesitancy? Do you think it would help? What stops you? Just so we could learn.
Well, you know, and it's a great question, and it's one I don't know the answer to. I think, you know, because you're right, it's how you and I met. It's how our relationship began. And the work I do, a call like this today, I feel like this is my support group. But to your point, I mean, I should return to it, because I don't have a community of fellow, what's the word, dysphagians, and people who know what I'm going through, and so you know, look for me at the next call. But and that's why one of the many wonderful things about working with you and the team at ASRL is that I know I have support from you guys. You have my back. If I did have a question, I can, you know, but it's the idea of support is, you know, if I hadn't have found you guys, how many years ago now, I don't think I would have found anyone, frankly, who would have understood.
Yeah, fair. Okay, we have a couple minutes left. What would you say to the clinicians listening who are treating someone newly diagnosed with dysphagia?
Well, what I would say is, and I've touched on this throughout, which is it is a physical impairment for sure, and the clinicians can address that. But you need to treat the whole patient, because what's happened here is with dysphagia is all of these layers of a person's life have now changed. And that, of course, has, rings around it, right? The caregivers and the social circles, the networks that a person orbits in, all of that gets affected. So yes, it is a physical condition, but don't sort of look at that in isolation. And then, and I'm being a little glib here, hand them, 2 or 3 swallowing exercises and say, go home and do these, we'll call you in, 5. Through all of this, I've had more dysphagia specific work done by Ashwini and the team in Hamilton at McMaster than I have here in my local community. I'm still waiting to get an actual SLP appointment and do a check-in to say, okay, where are we at? And I'm 4.5 years removed. Yeah.
I mean, I think that's where calls like this and why I partner with David, it's for that advocacy, right? Like, there are real people who are suffering behind these voices who are saying, we need more jobs, we need more coverage, we need SLPs and dietitians on every team, we need to be part of every appointment. There are real people who have real stories and real struggles. And as you said, it's not just the swallowing impairment, but it affects your whole life. And I thank you so much for being so willing to share this story, because I think, as you've highlighted so many times, you are not alone. You are not unique. I wish you were, but you are not. There's so many.
Well, thank you for that. But yeah, and when I met that young man on the call not long ago, it really struck me how he beautiful family and all of the things he went through, and I was both uplifted by seeing him and hearing his story, but also it made me sad thinking that I wonder kind of what other people in a similar kind of spot are we connecting, are we talking? I mean, there's so many other conditions and diseases, if you will, that have higher profiles. Of course, we all wish none of this existed, but that would be, unrealistic. It does, and I just hope that, by doing what I'm doing here with you and the team, can help others and also those who work with them.
Yeah, yep, I totally agree. Well, with that, we are kind of ending our time together. So I want to return to this idea on the screen that when we lead with empathy and evidence, we create space for people to be seen, heard, and nourished in every sense of the word. Empathy reminds us to pay attention to lived experience. Evidence helps us act with intention and confidence. When we hold both together, our decisions become more thoughtful, our care becomes more responsive, and our work becomes more meaningful. So thank you, everyone, for your time and for engaging in this conversation. Before we take questions, I want to put a plug for a couple things. The first, our National Dysphagia Support Group. I've put a QR code that will lead you directly to my lab website where which you can share with your patients, share widely. This is open to any adults with dysphagia and their caregivers across the country. We try to switch up the time every month so it works for all time zones. But please use this resource. Take a picture of this. We can also send this out later and it will be in the chat. I also wanted to put in a plug if you want to learn more or share more with your patients and their caregivers. David engaged in this amazing conversation with a caregiver, Maylene, and they talk about their experiences. It's on YouTube, on our YouTube page. I learned so much, and I know them both. I think your patients will feel seen and heard if they listen to this too. So please take a listen. And then lastly, I'm working with Nestle Health Science to learn about adherence to dysphagia recommendations from adult patients and their caregivers. We would love for you to share the link to this survey with your patients and their caregivers. We want to hear more. We want to know what will help so we can make everyone's life better and really improve the quality of life. So thank you, thank you, thank you. And we are happy to take questions.
Perfect. Thank you so much, Ashwini and David, for sharing all this insightful information, and David for sharing your story today. There are lots of wonderful comments in the chat about thanking you, David, for sharing your story and really bringing to light your journey with dysphagia and what that's looked like from your perspective as well. And as clinicians, what we can work on maybe and help support patients as well as caregivers too. There was quite a few interesting questions. This question's for Ashwini. People are wondering about the paper that you spoke about, physical activity and dysphagia. They wondered if you could share the name of that paper again.
Sure, that's actually forthcoming. We are just, okay. It's under review, but if you subscribe, we have a newsletter on our website, and we have our social media handle. Our Instagram handle is at asrl.mcmaster. You can also look for us on Facebook. We will share updates with that, but it is forthcoming.
Okay, perfect. Thank you. This question, David, is for you. The audience was wondering, did the surgeon or any clinician talk to you about the possibility of you developing dysphagia after the surgery that you had, or was it discussed at all before you had your surgery?
No, it wasn't, and I don't fault my surgeon at all. There's no, but remember the time we were in. I got the diagnosis June 5th, and I should say I sort of spotted the change in my body and went to my GP right away, who was magnificent in moving very quickly through the steps. And June 5th is a diagnosis. I was in surgery, I had a biopsy to follow, and then in surgery July 30th. So we were moving very quickly, and we were in COVID. Okay, so nothing was moving quickly in the medical system here in my city, and I'm guessing that applied to most everywhere in Canada. So I was grateful. I was told early on, don't, Google your condition too much or try and, learn so much about the surgery. And so what I purposely said, okay, look, I'm going to put my faith in the people I'm working with. I was very confident in the individual who was going to perform the surgery. And so I focused, maybe, and naively in hindsight, focused on, I have cancer. What do we need to do to get the tumor out? And it was on the spot where my left tonsil had been. It was HPV cancer. I forgot to mention that. What do? Get me to the place where I don't have cancer, that the tumor is gone. As I said earlier, I didn't know what base of tongue was. I didn't know that they were going to take an area around the tumor, which they do, and they kind of do some clear cutting, if you will. And I didn't know that base of tongue was in play as something that could potentially be part of this procedure. So it was, as I said, it was many months until I finally had a aha. So that's what I now live with moment.
Oh, wow. Yeah, quite the experience, right? To have gone through all that surgery and then, yeah. and then have it kind of another battle to fight, right, on afterwards as well.
Yeah, I wasn't expecting that part. I knew I was going to have some tough days, and I did.
Yeah.
And with the radiation, I opted not to get chemotherapy, but I thought, the last voice I heard before I went under, when I was wheeled into the room, one of the people on the team said, we're gonna really we're gonna be a little rough on your throat. And again, I'm lying there, I'm about to go out, and I thought, okay, well, then I guess coming out of this, I expect that I'll not be a strong voice. I would expect that I'll have several days of, some discomfort. And boy, was he ever right? Because it's not only did I have throat issues, I had, then swallowing issues, which remain to this day.
Yeah. Can I just add one thing, David, that we didn't mention is that, so David underwent surgery and radiation, and no one also spoke to him about the impacts of fibrosis.
Yeah.
So radiation-induced fibrosis, and how they would likely get worse around the 5 to 10 year mark, and how that might affect his swallowing. So that was, I thought I was having a very casual conversation with David in mentioning this, assuming he knew, and it was quite a surprise.
Yes. And this is Ashwini, if I'm, you're absolutely right. And that's why I'm back in orofacial massage and going through those treatments is, that's over and above the jaw stiffness. I mean, I've had to use, popsicle sticks or tongue depressors wrapped in medical tape to try and spread my mouth open. Because there was a period of time where I couldn't open my mouth fully to put not that I had a lot of options for food, to put food in comfortably.
Yeah.
There was another question from the audience, and this could be for both Ashwini and David, is that regarding the support group, how do you encourage your clients and patients to attend the support groups? Because many of the participants said they have a lot of hesitation that comes for attending. Do you have any tips or tricks or suggestions on helping support people to attend?
Ashwini, do you want to go first, or do you want me to?
I mean, I can go first. I would say it's what I can tell you from firsthand is that you don't have to share if you don't want to. Some people stay off camera. They just listen. They tell us from the beginning they're just going to listen. We ask everyone at the beginning what they're hoping to get out of it. If they have a question, they can ask. It's pretty low stakes. It's a pretty small group. And it's very welcoming, and I can see the hesitancy and the reluctance and why someone might be, but I think just talking about that isolation and the benefits of feeling seen and heard and hearing what works for other people might be really valuable, even if you hear it once.
I'll go to my situation when I joined the group the first time and met Ashwini and the folks with the lab and some fellow dysphagia patients. It was for me an opportunity to both listen, but also, because of my past as a broadcaster and as someone who's told stories and stories of others, I wanted to see how other people were characterizing their condition, and how do they describe it? At the time, obviously, I'm not thinking that it's going to evolve into the relationship I now have with Ashwini and the work I do. And we just recently finished up, yet to go public, a tip sheet for people to take on roles like I have, to speak publicly to groups, to clinicians, to caregivers, and talk about what it's like to live with dysphagia. And so it's both educational on a personal level, because I think learning about how somebody else is navigating it, I can pick up tips, and maybe they hear something from me. I've told my story publicly, both with Ashwini and through the lab, but also in media, on television and on radio here in Edmonton, and I think there was some some benefit for others who heard that. But I know that I benefited as well, because it was an opportunity to also, a little bit selfishly kind of get clarity on what it is I live with.
Yeah. Yeah. I will say, through the group, we've helped people find funding for things like a suction machine that they had to buy themselves. We've introduced people to new products. We've corrected how they were mixing thickeners, because we brought a chef in and talked about modifying comfort meals. It can be like the people who, we have a lot of regulars, I'll say that, because they find so much value in it.
It's amazing. Thank you. Thank you so much, Ashwini and David, for sharing all this information today. And thank you, David, for taking the time to share your story with all the participants today at the webinar. Before we end our webinar today, I would like to let you know about an upcoming learning module that will be available soon. It's Collaborative Care in Dysphagia, an interprofessional approach to dysphagia assessment. It's going to be presented by Ellen Andrews, speech language pathologist, Jane Duvestein, a combined OT-PT therapist, and Peter Lamb, a registered dietitian. And this learning module has been developed to help you learn practical steps to conduct a clinical dysphagia assessment that includes a mealtime observation. And the goal is for your patients and clients to experience reduced risk, increase mealtime abilities and enjoyment, and improve nutrition and hydration. So please watch for your email, and also take a look at the NHC Pro website for upcoming registration details. We have really appreciated your comments and questions, and thank you for participating in today's webinar. If you could please take a few moments to complete the feedback survey by clicking the forms option on the left of your screen. Once the recording is ready, you'll receive an email that has a link to the recording as well as your certificate of attendance. And we'll end the webinar now, and I really want to thank everybody again, and I hope you enjoy the rest of your day. Thank you.
Thank you.
Thank you.